So I'll just quickly cover a little bit about what we've learned about radiography and MRI. This is Arkle having an upright navicular view in the 60s. We've come a bit of a way since then. Radiography of the foot, I guess what all 3D imaging teaches us, and this is a CT image clearly, but it teaches us that what we're looking at is a very complex two-dimensional structure, three-dimensional structure on a two-dimensional image. And what we get from that is overlay of tissues, and that's what's confusing us in many instances. In many cases, the most important part of the navicular bone is this distal part here, and we can see that the pedal bone is overlying that in the lateral view, so it can be quite difficult to appreciate changes in density in that area. The upright navicular view, well, it is called the upright navicular because we use it primarily to look at the navicular bone. The distal border, as I've already said, is very important now in assessing whether there's any impar ligament desmitis, but this view is also really useful. I'll show you later for looking at areas where the ligamentous insertions of the impar ligament here very frequently cause little cyst-like lesions that you can detect really nicely on this view, and I'll show you that later, but this is a nice normal image. But often I'm looking at the distal border here, the proximal border, but very often also the coffin joint surface and the palmar aspect, the flexor cortex of the heel bone. The upright shot, and again I've said on MRI we can't appreciate foot balance, so this is still very, very important in your radiographic set. When we're trying to get nice, very symmetric sequences on MRI, these sorts of capsular distortions can often make it quite difficult to get nice images, but it's very important that we get this type of image to appreciate that and what may or may not be going on inside. Still very, very important, the skyline view of the navicular bone, but we know that it is problematic because we strive for this nice image with the clear definition between the medulla and the spongiosa, the cortex of the navicular bone. But the majority of the pathology, again, in most horses will be distal to that, so curving around and actually be present here. So a number of horses will have flexor cortex lesions visible on this view, but many will have damage a little bit further down, so if we make the angle a little bit more shallow, that's a rubbish radiograph, but actually it shows you quite nicely that there's an erosion on the sagittal ridge very distally. So the message really is taking multiple views, so sometimes the ones that your radiographer or you might just delete can actually sometimes hold some useful information. But these types of flexor cortex pathologies, which we can't even vaguely hope to see using even the best flexor cortex view, so these areas of little fluid accumulation are just obviously completely missed. But also we can miss huge lesions. It's amazing sometimes what you can miss, even with the best x-rays possible. These sorts of types of lesions where we've got this huge trunk of tissue that's gluing down to the deep distal flexor tendon beneath it. These are end-stage erosive lesions which have formed adhesions between those structures. Very tricky to see radiographically, even on multiple sequences, multiple views, and these types of lesions come in many forms. Just to mention, this is a huge, almost like a cyst-like lesion in the navicular bone. These horses can be perfectly sound, so sometimes these can catch you out as a very dramatic finding on a sound foot. So you have to look for what's going on in the rest of the navicular bone. You can see here this is clearly demarcated. We've got nice cortices. Compare that to the other three on the image where we've got very dense bone, we've got thickened cortices, so they're not, sometimes I think these horses are probably going to go lame at some point, but you can see those in sound feet. I showed a similar image to this previously, so this is a horse which has got what looks like perhaps a flexor cortex erosion, and actually doesn't. He has a cyst which communicates with the coffin joint of the on the dorsal surface of the navicular bone. So that would probably block quite well to a coffin joint, and then you come home with a navicular diagnosis. So it can sometimes catch you out. X-raying that, you might say, oh dear, we need to put this horse down. It's got an erosive lesion on its navicular bone, and these can actually respond quite well to coffin joint medication. So it gives you that little bit of extra information. So if we can't MRI the horse, what can we use now then to see, to indicate if there might be a soft tissue injury within the foot? So as I've said already, very often these horses will be lame on a soft surface with the limb on the outside. So this is a horse with a deep distal flexor tendon injury, and this is quite a classic presentation of that type of injury. We can look for mineralisation of the soft tissues. It doesn't happen that often unless it's gotten to such a quite a chronic extent, but hopefully you can see here in this horse with a partially ruptured lobe, you can see mineralisation in the deep distal flexor tendon. And then also actually there was some mineralising tissue within the coffin joint as well, so within the synovial tissue. We can use the soft tissue attachments to the navicular bone are very often implicated in navicular disease. So we can use these two ligaments, the collateral sesamoidean ligament and the impar ligament, to actually indicate whether or not we've actually got soft tissue pathology. So this is the collateral sesamoidean ligament. It comes across the whole breadth of the navicular bone and then comes around and glues onto actually distal P1. And when we have these dorsal margin lesions that I've already spoken about, they very often cause collateral sesamoidean ligament desmitis, and so they can end up with this sort of glued down fibrotic bursa that we were talking about earlier. They can actually get an indication of those on X-ray. This is rare, this is one that's mineralised, but this is very common. So you see this sort of blunting of the proximal border. So if you see this on an X-ray, you can be relatively confident that you've got collateral sesamoidean ligament desmopathy, and that's probably because you've got a dorsal margin DDF lesion. So it sort of usually adds up when you scan them. Impar ligament, similarly, so we know it's gluing onto this wide area adjacent to the solar channels in the pedal bone. It should be a very nice thin structure. So here it is, deep distal flexor tendon, the impar ligament here with fluid either side. And when we get problems, we lose that fluid because of adhesions and thickening. Can we see that radiographically? Very occasionally we can, and it's very dramatic in this case, but we should look for a smooth facies flexoria of the pedal bone and a relatively smooth endosteal surface. Compare with this case with very advanced distal border and impar ligament disease. We've got lysis and modelling of the facies flexoria and endosteal changes. Can we see impar ligament desmitis on an X-ray? Yes, when it gets bad enough. So we can see distal border invaginations, usually benign, but very often associated with impar ligament desmitis. And also, can you see these lucences which look like they're on the joint surface, which can catch you out? Because if we show you in this orientation, this is now the MRI scan that correlates with that. And distal border invaginations very nicely, and then we've got, these are the solar channels here and here, and these are cyst-like lesions which are located just here, so at the impar attachment. So when you're X-raying through there, you're seeing them through and thinking this horse has got coffin joint disease, and actually it's got impar ligament desmitis.